Alright, hi. We're going to talk about a neck mass. We have a 46-year-old female who comes into the clinic complaining about a mass that she's found on her neck. You immediately need to assess for patient's. You immediately are going to assess. I want to assess the need for immediate resuscitation. Go through the ABCs. Most likely not, but there's a possibility of. There's a possibility of breathing difficulties. It could be trauma, like traumatic thing, but most likely not. I'm going to take a history, present illness, when she first notices neck mass. When she first notices neck mass, can she go through the course of this neck mass? Has it been progressively enlarging? Has she noticed it before? Does it wax and wane? Does she have any recent history of a viral infection or bacterial infection, upper respiratory tract infection, any discharge from it? Is it painful? Is it mobile? Is it warm, erythematous? Location. That's the most important thing here. Constitutional symptoms: fevers, chills, night sweats, weight loss, anorexia. Difficulty swallowing, difficulty breathing, excessive salivation, obstruction of swallowing. Has she noticed any? Anything that makes it better or worse? Anything that makes it better or worse, or anything associated symptoms with it? And that's it. I want to move on to a review of systems. A little bit more review of systems now. Ask her if she has any bone pain, mental confusion, difficulty concentrating, pancreatitis, symptoms of GERD. Symptoms of pancreatitis, symptoms of GERD. Does she have any, sore throat, upper respiratory tract infection symptoms? Is she let's see. Okay. Heart palpitations. She gets chilled really easily. Sleepy. She feels very revved up. Excessive sweating, etc. Recent childbirth. Past medical history. I want to ask her about any head and neck cancers, thyroid problems, parathyroid problems, any immunodeficiencies, HIV, EBV, possibility of her having mono, tuberculosis testing, past year tuberculosis testing, trauma. Recent upper respiratory tract infection, past surgical history of the head and neck, past surgical history of the head and neck, past surgical history of the head and neck, most likely not. Any medications that she's currently on? Immunodeficiencies, autoimmune disorders, RA, lupus. Any cancers? Any type of cancers that she has? The men, parathyroid, pancreatic, parafollicular, pheochromocytomas, marfanoid habitus. Family history of macrocephaly, any cancers, thyroid cancer, parathyroid cancers, connective tissue disorders, etc. Past radiation exposure to this area, allergies to, allergies. Go over allergies. I want to perform a thorough physical exam, doing thorough head and neck exam, especially visualizing the also especially visualizing the oral mucosa, palpating the mass, quantifying the number of masses, characterizing is it firm, tender, mobile, associated with any structures, move with swallowing, move with breathing, is it cystic, is it firm, location is again the most important thing. Characterize the how the mass looks on external examination. Yeah. Yep. I want to move on to labs. Depending on her presentation, I could order a number of labs. Yeah, there's a number of labs I want to get. Initially, I want to get a TSH, T3, and T4, CDC, comp. Those are pretty standard as well. CDC comp, mono spot. I'd probably do a mono spot. Calcitonin. Yeah, I'll probably do a calcitonin. TH. Yeah, we'll do those. Depending on the institution, we'll do those. All right. If TSH is high, this is more indicative of a subacute thyroiditis or Hashimoto's thyroiditis. If the TSH is low, this is more indicative of a process such as toxic diffuse multinodular goiter or Graves' disease if it's normal. Now this is more indicative of several other processes, such as this could be a lymphocytic thyroiditis, papillary, medullary, colloid. Yeah, colloid, etc. Also, okay. So let's just say that the TSH ends up being normal. Now what are we going to do? We're going to do an ultrasound and a fine needle aspiration. Ultrasound to visualize the mass, see if it's really there, see if it's more likely cystic, in which case it would be an abscess and we would drain it and give antibiotics for that, or if it's more of a solid lesion, or you could probably see a colloid, with more of a colloid appearance. Most likely 80% of thyroid cancers are follicular, medullary, papillary. 80% of thyroid cancers are papillary, and those are characterized by somal bodies and orphan antinuclei. And papillary cancers are, they're associated with prior radiation exposure. So what we want to do is do the fine needle aspiration. If the pathologist ends up characterizing this as a papillary carcinoma, as a papillary nodule, we have characterized as a papillary nodule, we have two options henceforth, and our two options if the nodule is less than 1 centimeter and the patient has not had prior radiation exposure and there's no lymph node metastases, we can do a lobectomy. However, if the lesion is greater, papillary, 34-year-old or 34-year-old is most common, women especially, less than blah 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 blah. We can do a lobectomy. The margins, if it's greater than 1 centimeter or there is higher risk with radiation or lymph nodes, you do a total thyroidectomy. Now we will do a radioactive supplement them with Synthroid. Total thyroidectomy, supplement them with Synthroid, and monitor for recurrence, and then monitor for recurrence subsequently. If this and that's so that's the workup for a papillary nodule. Papillary carcinoma. Papillary carcinoma. Alright, so if this is benign, if it comes back benign, then hey, you just symptomatic during the course of the just remove it. If not, you just let it be. Just watch it. If determined or suspicious to have surgery to collar the nodule, this is benign. Benign, but could progress. Calling nodule, so you want to make it large, so you have a result. Follow up. Medullary carcinoma. Now you'll see this. You'll see medullary carcinoma because of changes in. You'll most likely see medullary carcinoma. You'll most likely see elevated PTH, low phos, high calcium. Low phos, high calcium, bone pain, constipation, medullary carcinoma. Medullary carcinoma is in 5% of thyroid cancers are medullary carcinomas. And now medullary carcinomas, you see these in MEN type 2A and 2B. And MEN type 2A includes parafollicular pheochromocytomas and medullary carcinomas. And 2 is marfanoid pheochromocytomas and medullary. Not parathyroid. Now, MEN1 is no, that's not right. MEN2 is, so it's parathyroid, pituitary, pancreatic, and then MEN. Parathyroid, pituitary, pancreatic, parathyroid, pheochromocytoma, medullary. Oh, medullary thyroid. Oh, okay. Medullary thyroid is parafollicular. These are your parafollicular cells. They secrete calcitonin. Calcitonin, blah blah blah. Metastatic medullary thyroid carcinoma is diarrhea, occasionally. Okay. Yeah, so that's okay. Yeah, so that's that. What else? That's medullary. Follicular. Follicular accounts for about 50. Follicular accounts for about 15%. Yeah, follicular accounts for about 15% of thyroid. Thyroid and follicular. follicular, um, and you suspect follicular, and you suspect follicular adenoma or um, follicular adenoma and follicular carcinoma. You got to distinguish the two because follicular adenoma, what you want to do is you just do okay, so if you find these follicular cells, you have to do a kind of sucks, but you have to do a lobectomy, which remove half the thyroid, and then send that to path and see if it's an adenoma or carcinoma. If it's adenoma, that's it. If it's carcinoma, you got to do a complete thyroidectomy. You got to supplement them with Synthroid. You got to do radioactive iodine treatments. You got to do that. Okay, so that's those three. Let's see. Anything else? Alright, so on FNA, if it's just lymphocytic, like lymphocytes, if it's that you can have acute lymphocytic thyroiditis. Yeah, you could have acute lymphocytic thyroiditis. Completely excise it, lymphocytic thyroiditis, radioactive iodine uptake, shows decrease in radioactive iodine uptake. Pretty much like subacute thyroiditis. I mean, it is subacute thyroiditis. It is. That's what it is. Alright, yeah. Okay. So if it's that, if you see these lymphs, like a lot of lymphocytes, a lot of inflammatory cells, you can do flow cytometry, and that might help you. Okay, if you see that. You see this? Okay. So, alright. You see these lymphocytic cells, lymphoma, radiation, subacute lymphocytic thyroiditis. What we want to do, what we're going to do is do a radioactive iodine uptake test. And this will help confirm this diagnosis. You'll see a decrease in radioactive iodine uptake or an increase sarcoidosis, tuberculosis, EBV, mono, these things present immunodeficiency. Being treated for lupus or RA or HIV, these are things that might go chiron differential. This is in a submental space, and there's enlargement, and there's difficulty breathing. This is more indicative of a low grade angina, and this is a very emergent condition, and must be treated accordingly. A lateral mass in a child, what you will do is you will do an MRI or a CT, and then lateral mass child, you'll do an MRI or a CT. I would like to go for an MRI. I don't expose kids that listen to radiation, especially at such a young age. And that could be a dermoid cyst, it could be a cystic hygroma, it could be most likely a branchial cleft cyst. And based on the results, we will take them to surgery and operate on that. Surgery for but if it's a midline cyst. So midline cyst is to present kids or adults. This is a thyroglosal cyst, and this has the potential to lead to an adenocarcinoma. Of thyroid